So today I'm going to start my respiratory assessment with a doorway or end of bed assessment. So here we're looking for any obvious respiratory distress in my patient. So are they using their accessory muscles? Is there any indrawing, nasal flaring, their work and rate of breathing? We're looking at their words per breath. Do they have pursed lips? We're also looking here for any obvious signs of airway obstruction, so any gurgling, snoring resps. Do they have a cough? Is it dry? Is it phlegmy? We're also looking here in the patient's home whether there's oxygen tubing, oxygen tanks, whether they have an inhaler, what medication are they on. So as you can see here, my patient is nice and relaxed. They're not using any of their accessory muscles. We can just take their rest rate here. So that's nice and normal. They're not using their accessory muscles. There's no indrawing or nasal flaring. There's no obvious immediate threats to life. Now I'm going to expose my patient's chest. So here I'm going to look and feel for chest asymmetry. So I'm going to look at my patient's tidal volume. Is it deep? Is it shallow? What's their work and rate of breathing? We're also going to look for any rashes, anything associated with anaphylaxis. So I'm just going to feel my patient's chest here, get them to take a nice deep breath. So any chest asymmetry here could indicate a fractured rib, a flail chest, tension pneumothorax or a hemothorax. We're also going to get our patient to take a nice deep breath. Just get her to take a nice deep breath. Did you have any pain when you took a breath? No. So we're assessing the patient's pain on inspiration or expiration because this could indicate that there's a muscular strain or something, a PE. We're also going to assess their jugular vein, so I'll just get you to look out the window there. So we're looking here for any jugular distension. So jugular chest distension indicates an increase in central venous pressure, so that's present in a tension pneumothorax. We can also assess for tracheal deviation, so I'll just get you to look forward. So any tracheal deviation is an indicator of a late sign of a tension pneumothorax. So if there was tracheal deviation, this patient would be considered status 1. They would generally be unresponsive and severely shocked. I'm now going to percuss my patient's chest, just the front of their chest. So we're listening here for a dull sound, so that's an indication of increased tissue density or fluid, and a hyperresonant sound would indicate a decrease in tissue density, which you would hear in a pneumothorax. So I'm now going to auscultate my patient's chest. Just get you to take a nice deep breath for me. So we'll just do the front of the chest for now. So here we're listening for wheezes, which you'd hear as a lower airway obstruction, so something you'd hear in asthma or cord. We're listening for stridor, which is an upper airway obstruction, so you'd hear that in croup. We're also listening for any congestion, especially in an isolated area, which could indicate a chest infection. We're listening for any crackles, so especially the lower lobes, which could indicate cardiogenic pulmonary edema. This patient's symptoms for this would be worse when they're supine. So now I'm going to get my patient to turn around so we can assess their back. So I'm just going to auscultate my patient's back. Nice deep breaths. And while I've got my patient's back exposed, I will also just have a feel again for chest asymmetry. So nice deep breath for me. So as you can see, the chest rise and fall is symmetrical. I would end my patient assessment with a blood pressure and an SpO2 reading.